If you haven't joined us before, we are the New York chapter of the Service Design Network. And the Service Design Network is a global organization. They run events, they have conferences, they do trainings, they have chapters all around the world, just like us, that are doing trainings, a lot of different events. We do one event a month, typically on the second Tuesday. We're celebrating today that it's Service Design Day, or the day after Service Design Day. But yeah, we run events. We had been doing them in person. We've now moved online, and we're working through that. So that is us. I don't know, Antonio or Kathleen, if you want to add anything to what we do as the SDN New York chapter.
Yeah, I guess before all this happens, we usually have in-person events every second Tuesday of the month, but now we are moving digitally. Our aim is to, I guess, connect the community and I guess build meaningful relationship to exchange our learnings in service design and our passion for things in the community in general. So welcome everyone tonight. Happy Service Design Day.
Sure.
Yeah, I would only add that I think, as we are moving digitally, we are also focusing a little bit more on content, sharing content of previous events. So we have a medium that we are very slowly populating with content from old events, and we're working as a side project on a podcast. So if you have interesting content that you want to share, or you have any idea on formats that can be more content based than event based, feel free to reach. We are here to learn with you guys how to navigate this new system of engagement and communication and community. And thank you for being here, of course.
Sure. And I also want to mention we are recording this event. It will be shared on Vimeo afterwards. So we usually share that with folks who weren't able to join, or if you want to recap or go back and look at what was shared during the evening. So I want to make note of that. And then before we get started, I also want to acknowledge current events. I know it's a very difficult time. People are experiencing for different reasons. And just I want to take a moment of silence, honestly, for the folks out protesting, just looking at this systemic racism that we're dealing with right now. I know it's affecting people in addition as another layer to the pandemic, and I want to make sure that we take a moment to acknowledge that. We're going to spend the majority of the time jumping in, talking about service design, really talking about the EDC and all the wonderful work that they've been doing. But I did want to make sure to acknowledge and just take a moment of silence. I'll just pause for a couple seconds here, and we'll just reflect. And then this was a sign that I saw actually this morning when I was taking a walk. I just need to get some fresh air and clear my head. And so I just want to remind people to take care of each other, and just sending love and just hoping the best for people to get through this difficult time. So yeah, I just want to make sure that we acknowledge that. And I know we're all experiencing that differently. But I want to take a lighter tone for the rest of the evening and really talk about Service Design Day real quick. It's a global event that's happening. It happened yesterday. We are celebrating on this Tuesday. But yeah, it's a time to talk about service design and all the different ways that we can give back to our local and global communities. And so what better way to celebrate than to work with the Emergency Design Collective, which is a newer organization that was started during the pandemic, during this crisis. And I'm going to hand it over to Nick in just a moment. So Nick, I don't know if there are slides or anything that you want to share, but Nick is one of the founders, and he's going to go through some commentary. Also, just to let you know, the format of this event is going to involve breakout rooms. If you haven't experienced those before, we're going to put you all into smaller groups so that you can converse with a smaller number of people. We're going to do that twice throughout the evening. So they take up to 15 seconds to get everyone in there. We're going to have a few people per group. So just to know, it might be a little bit jarring if you haven't experienced that before, but you'll be in a smaller room, and then you're going to come back into a bigger room, and we'll be sending reminders about timing. Each breakout room will be about 20 minutes, but you'll have some conversations with a smaller, more intimate group. And then we are working toward having another event in a couple weeks. We had George I come last year and speak. We're going to have him back, and he's going to be digitizing his previous talk, which it was a big hit about a year ago. So look out for that. And please be sure to rate our events on Meetup. You'll get an email after to give us some kind of a rating. Just let us know. We really appreciate the feedback and to figure out how we can better serve you. So without further ado, I'm going to hand it over to Nick, and he's going to talk about the Emergency Design Collective.
Awesome. First of all, it's lovely to be with you all here and to do this. I'm kind of celebrating that we went from maybe the very early awkward phases of all doing these Zoom things to now realizing we can be together for virtual events in a way that would never have been this easy if we all had to travel somewhere. And I keep reflecting that while none of us would have wished these circumstances on the world or anyone, it's given us all a chance to broaden our networks and make some new connections and new friends. And if nothing else, I'm in a day that has not had a lot of positive news and things to feel good about. I'm feeling good about being here with you all and getting to spend this time together. I want to share a little bit of, I'll introduce myself a little bit. I want to share a little bit about the EDC. And then Natalie, if it's okay, I'd like to call a bit of an audible and move up the 3 inspiration talks. And then I can come back and I'll give a little more context to the EDC. And that's because Amanda Salmon, who's with me, is my co-organizer of this event, and she's a trauma surgeon in the hospital today, and her time's going to be pretty limited. We're also joined by a dear friend and a former colleague, Matt Brown, who's a nurse, whose time is also a little bit limited, and I want to make sure that we get to hear from them. And Natalie, to get to hear from you as well. You're one of our sources of inspiration tonight. And then I can come back and add a little more color. So if we're okay with that, I'll just do a quick intro and then tee them up.
Definitely.
Cool. So I've got a background in starting and leading design and innovation teams inside of hospitals and health systems. It's been a pretty incredible opportunity most of the time, but it's also been one that I'm constantly reminded is really new. This idea of designing and doing any kind of service or experience design work or innovation work inside of healthcare is still a pretty radical concept. Where I think a lot of other industries have had that as a core tenet from their beginning, or at least went through a revolution where they realized that to truly create things that were usable, they had to also be desirable and solve real problems for people. That's a pretty new concept in healthcare, and it's one that I think is still not very widely adopted. People with backgrounds like ours often find ourselves as being sometimes kind of the lone weirdos inside of what are traditionally very conservative, siloed institutions. But the good news is we're seeing more and more of it. And one of the hopes I have for today in this conversation is just to inspire this group to think about healthcare as a place that desperately, desperately needs design in every way. When we started the Emergency Design Collective, one of our guiding thoughts was just the realization that our orientation to health as a society is very fractured and siloed and broken. We go to the hospital if we have something physically wrong with us, and the hospital knows how to treat a broken bone or a broken organ, but they don't know how to treat somebody's homelessness, and they don't know how to treat somebody's job loss. They don't know how to treat somebody's food insecurity. There are some organizations that try to work on those things, but they don't know how to treat somebody's chronic disease. So we have all these little fractured, siloed organizations that try to address some of the things that make up health. But we know that health is really broad. In fact, the things that we typically think of as medical health are really only about 20% of what make up our total health. Everything else is the neighborhood we live in. It's the jobs we have or don't have. It's the access or not to education. And so when the pandemic started, we realized that those fractures and silos were being stressed to the point of breaking in many cases, and that this was a time when we urgently needed to have design and doctors working together, working with public health people, working with other civic experts and leaders to think about not only how do we respond to their urgent needs, but how do we use this time to build systems that are better, more thoughtful, more usable by everybody. In the last 72 hours or week, we're also having the same conversation around what's going on in the world. And Natalie, I appreciate you holding that space earlier in this conversation. I just want to piggyback on that and say, To us, it's really clear that racism impacts health, injustice impacts health, inequality impacts health, shutting down voices impacts people's health. So those things don't feel taboo. They feel like the kinds of things that designers, that healthcare people need to lean into and be part of co-creating solutions around. I want to talk more about the EDC later, and I'll come back to that. But I wanted to set a stage a little bit. So tonight we've got kind of three different perspectives of what we might call life at the front lines of the pandemic. We've got Amanda, who's going to jump in just a minute, who's going to talk about what it's like to be working literally at the front lines in a hospital right now. We've got Matt Brown, who's a nurse who has been leading a unit in a hospital in Washington, D.C., who's got a lot of lived experience. And I'm asked Matt specifically to talk about right now, what is it like to be a nurse? Not necessarily what are his patients experiencing, but what are he and his colleagues experiencing? It's really easy for nurses to sometimes not be able to get we celebrate them as heroes, but we don't often know what it is really like to be a nurse and work a long day. And then Natalie is going to share her experience on what it was like to have COVID and what it's like to be recovered or recovering, and both kind of the front end of that experience, the living of the experience, and what it's like today. And Natalie, I've also forgotten your co-collab. Emily.
Co-recovered individuals are gonna speak, so we'll kind of do a back and forth there.
Cool. Emily, I'm so sorry. I'm trying to write down names as we go here, but I'm
no worries.
So that'll be our inspiration format, and then have a chance to break out and discuss some of the things you heard, find some themes, find some disparities, that kind of thing. Natalie, before I turn this over to Amanda, anything else you want to add for framing?
No, I'd really say just listen for anything that surprises you, anything that feels like a system that's broken, anything that really calls your attention, something that I would take a note, whether you use a digital notepad or something inside. But yeah, just listen and hear their stories.
Well, cool. And then I'll come back at the end and talk a little more about the EDC, if that's okay. So Amanda, why don't I turn this over to you?
Sure. Thanks for having me, all. So as Nick said, I'm Amanda Salmon. I do trauma surgery, elective general surgery, emergency general surgery, and critical care at UCSF. And I work at the San Francisco General Hospital specifically, which is the only level 1 trauma center in the safety net hospital for the San Francisco population. This is sort of unscripted, so I thought I'd talk about 3 points in this COVID journey, and just do a little bit of storytelling around it, and try to give you some, if I'm being reflective, sort of what my perspective was. And so let's start with the beginning. I've had the privilege of working most of these weeks on and off. And I have to say, for people in healthcare for whom we're used to being experts and we're used to some semblance of stability in our daily workflow, the early was really hard. So I'm a working mom. My 2 boys, 3 and 5, their school was canceled. Our au pair quit and went back to the Czech Republic. And my husband, who also works in the business side of healthcare, was working around the clock trying to get access to testing capabilities. And our backup childcare, which is both sets of grandparents who are in their late 70s and 80s, were being socially distanced. So we were scrambling personally. And I think this is the case for many dual working families and many families in general. I'm a trauma care provider, so while volumes went down, trauma doesn't stop. People don't stop having emergency surgical problems, but they're coming in late, and it felt like people were sicker. In the early days, everything was changing. From day to day, what do you wear PPE, and what can you have, and what do we have, and do you wear an N95? And our professional organizations were saying you should wear them in the operating room, and our hospitals were saying you shouldn't because we didn't have enough. So we knew we were getting guidelines that weren't based on what should be the standard of care. And we knew we were completely off trajectory on what was the standard of care. One of my first memories is, so I was on a phone call, actually, a conference, now a Zoom faculty meeting. If nothing makes me feel more isolated, it's having a faculty meeting by Zoom. And the trauma pager went off, and it was a stab wound to the chest. And I went sprinting over there, and it was beyond the adrenaline of like, how do I provide trauma care and keep this person alive? It was, do I have my N95, which is in a paper bag, on my belt, and am I supposed to be wearing it? And what's the PPE? And we get in there, and the guy's very sick and has to be crashed down to the operating room. And we're all trying to figure out how to provide this somewhat, I mean, trauma care is chaotic by nature because it's people dying in like rapid sequence. But to do this in the setting of if we had the PAPRs, I mean, there's no 15-minute wait after you intubate a patient. It was sort of all hands on deck. And I remember feeling, I think everyone felt, even though there was 20 people in the room, I think people felt scared and alone, that we were sort of in a data-free zone. We were trying to provide care. We had a human life in front of us that we had to save. And we were also, for the first time, sort of worrying about our own health. I remember operating on this gentleman and wearing an N95, and it's so tight, you feel so claustrophobic and your heart rate's going that you're trying to like provide care in these new constraints. We didn't have the right face shields. It was certainly an interesting time. And he did well. He survived. He left. He did not speak English, and he didn't speak Spanish, which is usually our second go-to. Most of us speak English and Spanish in San Francisco. He was from Africa, and he spoke an African dialect, and he had no family at the bedside. So he recovered after having a stab wound to the chest, in an ICU with drains in, probably getting, I would say, the best care he could get, but not having the support system that is normally there for him, both to keep his spirits up, but also to provide translation services, bring in food. And I think it was that time early on, we realized while we might be feeling scared and alone, our patients were really scared and alone. And in some cases, they were dying alone, which was very hard for everyone. I think that we stopped being scared, and then it just started to feel lonely. And socially, we started to see sort of social repercussions of this, where we all know that COVID has disproportionately impacted people of color, but the social repercussions of COVID, of schools being out, of job loss, have disproportionately impacted people of color and our more vulnerable populations. I'll give you one example. We've had children come in with traumatic injuries that wouldn't have happened if they'd been in school because they were either with siblings or left at home. And we would have to get special permission for parents to be at the bedside, and everyone's sort of isolated. If you're a teenager or 19, you didn't get a parent at the bedside because of all the social distancing. And then I think I'll talk about now. So you saw everyone sort of rev up, and we do mass casualty care, we do emergency care. We can push to the limit, because usually we're pushing to the limit in the context of a catastrophe, a mass shooting, a mass casualty. There's a sort of an end point to that. And we're often doing it in an environment that still functions. Our social systems are still functioning. Our childcare is still functioning. Our kids are still in school. The people around us are still sort of emotionally held together. And now you see sort of the whole world is experiencing this. So I would say right now what we're seeing is, I think people are depleted and resources are depleted. Now we've stocked up on our personal protective equipment, but one of the repercussions of this COVID pandemic is that people aren't organizing and doing things like giving blood. So as just, we knew this, there were warnings about it. The Emergency Design Collective worked on how do we set up blood drives in a safe way. And we have a blood drive going at our hospital right now, but I just got a text today that we are critically low on blood. We have 40 units. And so you're thinking about how you ration care, or how you will ration care or provide care, given that you're resource constrained. I think I'll end on, it's almost cruel. I mean, if there were fires going on in California, it would almost be cruel. We were very lucky when it comes to sort of COVID and sheltering in place. So we did not see the numbers that New York had, and we saw our colleagues, breaking in New York and on the East Coast. But now we're seeing social unrest, and that is the patient population we serve. They've already been disproportionately impacted by COVID, by getting ill, by all the social repercussions, and now we're dealing with reopening of wounds, or maybe it's the airing of what has been in the background for many people all along, and not even the background in the foreground, which is just the social injustice and racial injustice. And so I'll end on something positive. The trauma team finished rounds today late. It's been we're not that busy, like we have 20 or 30 patients, but they're really sick, and we had a really nice moment of silence across the University of California, where everyone went outside and took a knee and sat for 9 minutes. And I'd say with all the logistical things, all of the challenges of PPE and resources and redesigning workflows and rounding by Zoom. I don't know if you know what it's like to round on patients by Zoom, but it's not a thing we've ever done. And the sheer resilience of people, and that despite, pandemic and social unrest and all these horrible things that are going on, people can still come together and celebrate the community that we've built here. And so I guess I'll end on that note, which is, this COVID has been upsetting. The social situation, leadership in our country has been upsetting, but I think it has reinforced to me the beauty of humans and the fact that they're resilient and they'll work together. And seeing the Emergency Design Collective that's come together, started as an idea between Nick and I, and it's grown to 500 people, and projects that have made PPE and developed systems that people can stand up their own blood drives, and just the power of humans and the creativity of humans and the ability for people to use design for good. There has never been, I think, a more urgent time for design and service design to play a role. And it's not going to end as people get sort of fatigued of COVID. I think I'm calling this, as a public health practitioner and a designer, this is not just the permission, but this is the mandate that we have been waiting for to put this into the forefront. And so for those of you who are listening, and for those of you who are gathering, I'm so incredibly grateful. I hope you show a little bit of love to healthcare to push service and design forward, because it's certainly an industry that needs it. And when you think about the design that you do, as Nick pointed out, the social determinants of health, how we live, how we educate people, how we develop our cities, how we provide childcare, those things impact health more than whether you're taking a statin or, even genetics, I think. And so I think we can think of this as a new healthist movement, and that everything we design, we can take a health lens to. And I sort of challenge you and invite you to join me in that journey.
That's awesome. Thanks, Amanda, and thanks for spending the time, especially while you're in clinical duty today, given that perspective. I want to tee up Matt Brown to just pick up right there and talk about your experiences, Matt, being a nurse and being a nurse leader. You also manage and lead a team of nurses, and I think you're going to have a wonderful perspective. I'll also chime in and say that Matt and I got to work together when Matt was our nurse innovator in residence in our embedded design studio in a hospital together. So I'm excited to have his perspective here. Matt, are you on the line?
I think I'm good. Can you hear me?
You are.
Yeah. Thanks, guys. I appreciate the intro, Nick, and the space to share with you guys. The unit that I run it's just a general med surg unit, but we are blessed to have the most negative pull of airflow in the hospital. So we became the default COVID unit. And a lot of my experience was wonderful to hear. Amanda was really the same. The beginning was like, what the hell? You got policies that are changing like minute to minute, like literally telling them something in the 0700 huddle and having to pivot at like 1400. It was a lot, but it was like this high. You were just so fired up to get everything set up. You knew this thing was coming. You didn't know what it was going to be like, but it was a big push, a big push, a big push. And then we peaked at some really sick patients. And what ended up happening was I've only done med surg. I've never managed ICU. So I actually got moved from my unit, which is now the complete sealed off COVID unit, so that we could take ICU and more critical patients up to that unit. And they put me on a different med surg unit, which was just like, I think now in the context of everything and of emotion and just human life was nothing. But then for everybody, it was like, whoa, we didn't have a single person for 8 weeks that got sick. And my whole mantra to the team was always, you should be kind, but we need to be extra kind right now. We've got to stay calm, because getting geeked is not going to help anything. And we've got to be confident, because like Amanda was saying, you're getting sort of mixed bag about the PPE, but I was like, if you start getting in your own head that this stuff doesn't work, you're not going to be able to do your job well. So you got to be confident. And they were. And so we were fortunate at my hospital. We didn't have to rock trash bags or anything like that. We had the PPE we needed. Really tried to preach about being good stewards of the PPE. And it was, yeah, it was that really big buildup. And then we had patients for a while, and now it's a whole different sort of managing being furloughed and managing who's being put on call all the time, and sort of this lull of things. But the things that have carried through. So from the beginning with that surge was figuring out the workflows and figuring out how the work's going to go. I never used SOP, a standard operating procedure, before, but good Lord, now we've got them for everything, and it's good because it makes the work consistent and helps keep people safe. But the things that impact the team the most right now are senses stuff, like not being able to hear because the blowers are going, and if you've got the PAPR on or even just the N95 in the face shield, you can't hear anybody. And it's really, including your patients, which makes it really difficult, especially if they're hearing impaired. And then not being able to see if your face shield like fogs up, or if your PAPR, like having to change that out, like that is and those two right there combine to prevent what all I talked about, just because I wanted to get more, I check in my team all the time, but I knew I was gonna be looking at all you guys on the screen and figure I better have more current, what are you feeling right now? And it's a barrier to do what we're called to do, be in the room, be at the bedside, interact with the patient when you can't hear them that well, you can't see them. And then icing on the cake is don't spend too much time in there. You got really try and cluster your care, be at the bedside and get out. And that is the hardest part for everybody. It's just, you wanna, cause Abdul, one of my nurses, said to me, he's like, you can see they're scared and I'm kind of scared too, but I don't want to be in there too long because then I'm risking exposing myself. So it's just a complicated thing to try and approach. All this is, right? That news not breaking, but to go at this in a way that is just contradictory to what we've always wanted to do as nurses, be with the patients and be with their families. We've tried to set up like proactive calls where if you've got a family member that we should be talking to, we'll try and call them once a day. One of the things that they struggle with is the tech and Zoom and being able to, where patients have iPads in their rooms, but to like set up a Zoom call for a family takes, time at the bedside with them. And then it's just time. It's still busy. And so to take 20 minutes to try and show somebody how to use one of the nurses said, it'd almost be good if I just had like a little tech helper that could help me sort of, run around, check on my people that might be willing to use this technology. Cause we also have, we use Epic. So we have MyChart Bedside as an option that I think would help a lot of patients, but that it's got to be set up. So all the sort of sensory things that it's impacted for right now are pulling us away from what we're used to doing. And somebody, Natalie, it might've been you in the beginning, was saying hugs, daggone, we miss like when you lose somebody, or when right now, even just, I try and make sure to check in as people, they're nurses or docs or secretaries or whatever when they're at work, but above all, they're people. And those purposeful and personal check-ins they lose the feel. Just, it's sort of between the mask and the not being able to be as close and to keep the social distance. It's really, and we get it, everybody understands why, but it's definitely cut down on the human feel of it. That is a big thing for us. But keep on, I'm not gonna say keep on keeping on, because nobody's ever had to keep on with this, but we will. It's just trying to find how to get back elements of what we were used to, while simultaneously recognizing, understanding nobody knows what normal is going to be, right? I feel like no matter what you're doing, you sort of are trying to work through that. But for us, trying to take care of 6 scared people without their families and wanting to be with them and not feeling like you can do that safely has been, I'd say that's best as I can in the 5-minute clip, ball up, sort of how it's been going. I appreciate being here though. Thanks for inviting me, Nick. And I appreciate if you guys can make some inroads on healthcare, woohoo, that would be, certainly use it.
I know both of you all are borrowing time you may not necessarily have right now. I just want to maybe just, Natalie, I'm sorry, I'm calling another audible, just to ask if anyone has 1 or 2 quick questions for either Matt or Amanda before they have to roll off. Just while we have this frontline expertise here, if they can clarify anything or elaborate on anything, maybe give them the time to do it.
Is it all right if I ask a question?
Yes.
Yeah, please.
Okay, awesome. So you're saying that you're putting new policies into place that weren't there before. Are any of these new workflows or policies things that are going to extend beyond treating COVID patients, things that you feel like are now part of your practice that you're going to use for working with other patients as well?
I think for masking, I don't see that going anywhere for a while. For everybody that's on campus, visitor restrictions, I'm not sure when they'll be lifted to some degree. I like being able to, like, Zoom wasn't an option for patients and families before. I'm thinking that will stay and that'll be good, but then we'll need more. I need everybody to be confident in that. Other thing, like some of the workflow unit specific stuff will probably, as long as it stays a lockdown COVID unit, will stay, but I don't think that a lot of that would be like it wouldn't make sense to do some of the things we're doing there on other units, because we staff a little bit differently, because like dietary, they're not delivering trays on the unit. They push a cart and nurses deliver the trays in the room to cut down on how much PPE we use. Stuff like that won't go anywhere else, or won't go to, like, wouldn't be as scalable. It's not going to go to other areas, I don't think. Answer your question, Greg?
Oh yeah, that was perfect. And thank you all for sharing this. This is like amazing stories, and it's just really it's like an insider look that I don't have. Like, I have inklings of. It's very interesting to hear this all firsthand.
Thanks.
I have a question. So in terms of talking about some of the things you're dealing with, like now managing being on call, furloughed, or it sounds like some scheduling issues. When you are working, I ask because I have a friend who's a ER nurse here in New York. Are you like 3 days on and then 4 days off, or like, are people sticking to that schedule?
Yeah, I mean, it's usually 312s. Early on, there was lots of opportunities for picking up extra. There hasn't been lately, but we try and give them as much agency as we can over schedule. So if people generally like 3 in a row, we'll let them do that. If they're 2 on, 1 off, 2 on person, that's the scheduling. The hard part with that, and it takes like hour and a half every day, is looking at who's been furloughed recently, who's been put on call. And then for us, because of the COVID unit and then the non-COVID unit, you're pooling basically 60 nurses together and trying to figure out, all right, well, this person got furloughed last week, but they were also put on call, and just, you want to be fair. And I don't want people to be ripping through their PDL when they don't need to. So that's been scheduling takes more time than it's important. And I want them to get the time that, I want it to be fair, but it's just it's one of those things where you just eyes roll back in your head a little bit going through it for that long.
And do you also have union issues where you have to like work certain amount of hours or anything like that?
No, we do not have, we're not a union hospital. There's no set parameters around how much we can, certain like agency people or contracts, there's rules around how much you can furlough them, but other people, we can sort of do what needs done.
Thank you.
Kate, sorry, Kate and Greg, I was on mute. I think there's a couple, from a how we provide care perspective, I think there are things that will change the way we practice care indefinitely. I think one of them is remote care, like making everyone show up. I mean, for our patients, they have to take 3 buses, they take their children, they come and sit and wait for 2 hours to be seen. We pull up their shirt, we're like, your appendectomy scars look great, see you later. And they're like, I missed a full day of labor. I had to take 2 buses in the rain. So I think remote care, and I say remote care because I think telehealth is constraining. I think remote care is here to stay. I think there are some other huge changes, I think, at least in the near future, which will have long-term ramifications. I think we are becoming a flexible system. So for example, we're preparing for the next 1 to 2 years to have to be able to expand and shrink our capability to provide care. So complicated things like the operating room, responding to bed availability, how we book our patients, what kind of patients we book. Before it was, I'm Dr. Salmon, I want to do 3 hernias today, or I want to do something complex and everyone else wants to do something complex, and all of a sudden we don't have ICU beds, right? and then we're out of ICU beds, then we're on divert because we're the county hospital, and then everyone else in Sanford, every other hospital goes on divert because they fill up because they take the patients we can't take. And because we're the trauma center, we don't go off divert, but they do. And so what we do, the little micro things of how we allocate beds, how we move patients around, how we bring them in, impacts the entire city and county of San Francisco. So this necessity to be flexible, I cannot see us not being better and more flexible in a more dynamic hospital system after this. And I think the third is that the archaic way of FaceTime and everyone's sitting for teaching and education and rounding, and like we all sit and we all walk as a pod and cough on each other. I think that's going to change. I think we're going to become more remote. I think we're going to be allocating people more smarter, and engaging with communities and patients' communities in more dynamic ways than we did traditionally, which was like, if you were at the bedside, you were at the bedside, and otherwise you weren't part of the conversation. And I think those are three things that are from systemically going to change without a doubt in the future.
Hey, Miss Amanda, can I ask you a question?
Yes.
I have a question, right? Because you mentioned like 3 hernias and all that, and remote care.
Yes.
So I'm a person who suffers from hernia mesh complications.
Oh yeah.
I'm kind of in limbo right now, you know, with trying to go back to New York City to see a doctor. I'm sure you know who Dr. Brian Jacobs is. So I'm trying to go see Dr. Brian Jacobs over there. But, you know, if I had to do this all over again, right, what would remote care look like? How would the doctor be able to examine the hernia and stuff like that remotely?
So that's a really interesting question. And that's like the workflow is who needs to come in and who doesn't. And we're figuring that out now. Like, so we traditionally as surgeons, because I think historically we were like all powerful and had to do and be and see everything and, you know, didn't play nicely in the sandbox. We had to see everything and touch everything. So, you know, you have a straightforward surgery. We call you, you have no complications. You said there's no redness or swelling on your hernia, on your surgical site. You probably don't need to come back in. If you are being pre-opt for surgery and someone's already seen you, like there are things you don't have to come in for, but there are also warning signs, like someone who's having complications. And so what is that workflow? What is that? How do we screen those people? How do we identify who comes in, who doesn't? Who can just do a phone visit versus a Zoom visit? Who could do a phone visit and have a visit in the community, you know, at the assisted living facility or the homeless encampment or whatever it is? Like, I think we need to be thinking more creatively about how we can provide care outside of our 4 walls. And the answer to your question is, it probably wouldn't for you if you need an exam, but we don't know who those people are. And we have to figure that system out. And we're going to require collecting data and trial and error.
I have a question also, Amanda.
Yeah.
Can you hear me? Can you explain the difference between remote care and telemedicine?
Yes. Telemedicine is a solution, right? So we do it by phone. I'm saying remote care because I want to leave the possibility that it's something better and bigger than just phone or Zoom. That maybe in the future we're moving towards, you know, an old school practice of sending people out in the community, particularly for our vulnerable populations, to meet our patients where they are. That maybe we're using wearables or other, you know, technologies to do some of the exams. You know, why does a pregnant woman have to come in so that someone could put an ultrasound on their belly? Why can't she just do that? So I say remote because I want it to be more, hopeful than just we're going to be calling each other or Zooming each other for visits.
Okay, thanks. That was really interesting.
I'm the one who kind of changed up our schedule here a little bit, so I might also try to be the one that gets us back on track. I think I could certainly sit here and have a fireside chat with Amanda and Matt for the rest of our time together, and we might need to find another time to do that, just because it's a perspective that, unless you work in a hospital, most of us never get this kind of insight into. But I want to make sure we kind of keep our theme and our plan and hear from all 3 stakeholders. And Emily and Natalie, if I could tee you all up to maybe tag team talking about your experiences of everything from contracting and diagnosing and surviving to what it's like to be in the recovery phase.
Sure. And happily, if we like these conversations, I think we could set up additional sessions with the community. So let's continue to talk as we can. But hi, my name is Natalie Kuhn. I live in New York City, downtown Manhattan to be specific, and I had COVID-19. Emily.
Hi, I'm Emily Fishbane. I live in Brooklyn in Kensington, and I also had COVID-19. Fortunately, I'm pretty sure I'm 99% recovered and happy to share my experience.
Sure. So we'll ping pong this a little bit of actually improv for us. So we will go back and forth a little bit. I'll share a little bit and then she can share. For me, I was sick, I guess, in the beginning of, in quotes, when it hit New York City. So really the second week of March for me is when I started to notice the first symptoms. And honestly, in the beginning, I thought it was in my head. I knew that a lot of the symptoms were fever, cough, shortness of breath, those sort of things. And I felt that maybe I manifested them with my stress and anxiety, and I must be making this all up. And so for me, my first experience or first portion of the virus was lighter symptoms, honestly. And then by the third week of March, so I guess like a week into my experience, they became quite severe and quite difficult to ignore. For me, I did have shooting chest pain, and it was unlike any cold or flu that I've ever had. And I would say if this was a March any other year, I would have gone to the ER without question. But I mean, who doesn't go to the ER if you feel stabbing chest pain that wakes you up in the middle of the night? That's not something you usually try to ignore. But in these times, in pandemic times, I was trying to ignore that and trying to figure out what is bad enough to go to a hospital, what is bad enough to call 911. I live alone, so if I became incapacitated at any time, the walls are thick. I don't really know. So that's the intro, I guess, to my experience. I can talk a little bit more about diagnosis, but I'll pause for Emily.
My experience was way less severe than Natalie's. I'm fortunate. I live with my husband. I then gave him COVID-19, so the two of us went through it together. Fortunately, we were able to care for each other for the most part. We were, not the sickest that we were at the same time. For me, my symptoms, I think it's not totally clear, like Natalie, when they started, but it was like April 10th-ish, and I actually am using a symptom tracker that Natalie sent me midway through what was going on, which was helpful. Exactly for the same reason as Natalie was saying, so that I could say like, no, yes, I have symptoms. I'm not making this up. This is not like a malaise. And then at a certain point, it became clear that it was like, not something that I could say, maybe I just have a cold or maybe I just have the flu. For me, I never had a fever. I had a dry cough for a while that felt like I had swallowed like cat hair. That was just a bizarre thing. And then from there, it moved into like intense fatigue. And there was a weekend where I took a day off work. There was a weekend I just slept the entire weekend. And then on Monday I said, great, I think I can go back to work. Cool, I'm good. And midway through the morning, I had what I thought was a panic attack. But I think in retrospect was actually a respiratory event. And I said, okay, I have to not be working right now. And I thought that was like having trouble breathing. And there were a couple of other weird symptoms, but I would say that was the most severe that it got. And then loss of taste and smell was the other like major marker that like, okay, I know that I have this even before I was tested. But go for it, Natalie.
Sure. Yeah. And so I was going to talk a little bit about the experience in getting medical attention.
Mhm.
I did have two different virtual visits with doctors. The first one, again, early on in the symptoms, I wanted to know, I'm a designer, I love to test and learn. I wanted to know what was I to do if I got this. In the beginning of everything, I don't know if people still feel this. I had the sense that everyone was going to get COVID-19 at some point. I mean, that probably is still the case over time. We'll just hopefully flatten the curve or continue to do that. But I would say I wanted to know what options I had. So I had a first call in which I was unable to validate that I had a fever. I felt hot, but I didn't own a thermometer. I actually had to have my mom send me one because they were sold out everywhere and online. I didn't want to worry her, so I didn't tell her to overnight it. So it took about a week, and I still was feverish at that time. So by the time I had my second visit with the doctor, so the first one, they just said, yeah, chest pressure, you're probably stressed. Anxiety has the same symptoms as some initial symptoms as COVID. So the chest pressure that you may feel, it could be attributed to anxiety. So as my symptoms, and I had muscle spasms, I had a lot of crazy abdomen shooting pain. I was like, what is happening inside? But because I didn't meet the criteria of what COVID was defined as, I didn't draw any red flags, especially without that initial fever. So the second appointment I had, I was diagnosed with an upper respiratory infection. Sounds a lot like COVID-19, but again, I didn't have the test. I wanted to be safe and stay at home. Again, that's always finding that balance of like, what is bad versus bad enough to go into a hospital. I'm a young person. I don't have immune issues. There's a lot of like ethics for me, I would say. And then I'm also very cognizant of time, and I want to make sure we can talk into small groups about this. But I'd say what finally happened to me is what's creepy about my symptoms is they would get worse at night. So I was going to bed around 7 p.m. and then waking up 2 or 3 a.m. in some sort of new pain or symptom or something. And so for me, when I eventually did end up going to the hospital, I'd woken up with muscle spasms in both of the back of my legs, and the pain was like very stabby. I've never had a heart attack, but I was like, am I having a heart attack? And I had to make a decision in that moment. Do I try to tough it out and just wait? What happens if I wait? Does that mean that I get worse? And how do I call 911? Because I know, talking to the other two doctors, they said, go to the hospital if you can't breathe. So if that's my limit, if I'm waiting until I can't breathe, then how do I even get to the hospital at that point, especially living by myself? So I did make a decision in the middle of the night to go to my local ER hospital. That I almost feel like is another 5-minute conversation. I appreciated the protocols that were put in place. They spoke to me through a speaker. Everyone was fully dressed in different protective gear. But I found out 3 days later I did have COVID-19. And to summarize, I guess I'll close out my part, and then Emily can close out your side of this. But you're really on your own as a patient if you're not in the unmanageable category in which you go into the hospital, regardless of mild to moderate symptoms in the manageable category. I would say it's your immune system on deck. And I think that for me was mentally taxing to be like, there are no antibiotics. Either my body fights this or it doesn't. And it was a real touch and go couple weeks. And post that I had pleuritis, which is lung inflammation from fighting the virus. So I've learned a lot about what your body does when it's being attacked. But so it was I would say 6 to 8 week experience for me, but fully recovered as far as I know right now. I've even been starting to run again a little bit, walk, run. But yeah, so I'm really lucky and grateful, and I know this has impacted people in a lot of different ways, and folks have lost those they care about. So I'm just grateful, and that's my story.
Well, I'll be quick, but I'm grateful that you're better. That was really scary, kind of hearing from you what was going on and not even hearing the whole thing. So I'm glad you're better, and I'm glad you went to the hospital. I think I have a similar impulse to Natalie, although my symptoms weren't nearly as severe, of like, I want to stay away from people. I want to keep other people safe. I don't want to take a test that could go to a frontline worker. And also, what are they going to tell me anyway? Even if I do call them, they're going to tell me, you know, take care of yourself with supportive care the same way that you would if you have a cold or a flu, because we have no answers for you. So I actually first called the doctor, and I'm a, not to, no sponsorship here, but I'm a patient of One Medical and I'm a big fan. And they have been doing telemedicine for a while. I actually called them initially because I was having a weird, like, I couldn't raise my arm to this height. First, I was having like intense muscle weakness. So I forgot about that. Natalie, I also had like intense muscle pain and muscle weakness. It was just out of nowhere. And that was about a week before I actually started feeling sick. Eventually I did consult with them again over the phone, and they said, well, do you want to get tested? And I said, well, yeah, of course I want to get tested, but I don't want to take this away from someone else. And they said, thank you for the sentiment, but honestly, at this point, we have plenty of tests. I said, oh, okay, that's the opposite of what I've been hearing. So I drove myself over to the site where they were. And actually, I kind of want to write this up as a service design case study where they're like, they just handled the, from telemedicine to personal, real in-person experience really, really well. And got tested, got my results the next day, was positive, and actually was feeling much better after that point. But I think similar to what Natalie was saying, like, even though it was a physical ailment, so much of my feelings around this have to do with the anxiety of like, okay, I'm okay now if my symptoms stay where they are, but I don't know if they're going to get worse suddenly. So the anxiety about that, not knowing, guilt about getting tested, guilt about recovering fairly easily, although I'm very grateful. And then uncertainty after the fact of who to tell, and like not wanting to worry people and not knowing if people would be weird about it in some ways. And I'll wrap it up, but the last thing is just the first question that most people ask me is, do you know where you got it?
Yeah.
And I think that's such an interesting question, because I think that's people wanting to kind of separate themselves. There's a lot of isolation, not just like social isolation here, but there's a lot of isolation in like the masks and just the way that people want to say, okay, well, you clearly made a decision that got you sick. If only I can avoid that, I will be safe. And I think there are just tons of social ramifications that we haven't even begun to unpack yet. And I'll end there.
Yeah, I feel like the need to say that when I went to the hospital, it was not busy. I also had the same guilt of like, I'm taking somebody else's bed. I'm taking somebody's test. So there's a lot of guilt, and the symptoms do go back and forth. So that fear of, will it get worse? That actually did happen to a handful of my friends who were also sick. You get much better, then in the middle of the night, you wake up with something that's incredibly worse. But anyway, that's our convo.
Just to pick up on that theme, we said at the beginning of this that we're realizing how the pandemic is really shining a light on some of the fractured and siloed and broken parts of healthcare. There's a analogous thought here to that idea of like going and looking at extreme users. We're living in an extreme situation, and it's showing us some things that we wouldn't normally have seen or learned about, at least en masse, the way we are right now. We did a big project at Johns Hopkins years ago where we were looking at the experience of being a patient, being an inpatient in the hospital, which is a thing that thankfully most of us don't experience or experience for a long period of time. And one of the number one sentiments was, I don't want to ask for help. I don't want to push the call button because I don't want to take away from somebody else who might need it more. And what I'm hearing you both saying is that's really on kind of front and center during this thing, is even a fear of going to the hospital because somebody else might need it more. There's a challenge there to be worked on for sure. What if I just do a real rapid tee up of the EDC? That's what we were going to start with. I'll just, and then we can go into the prompts and the breakouts. Does that work, Natalie? I'm seeing you nod your head. So
Sounds great.
cool. Will it let me share? It will, I think. Cool. All right, I'm going to do, this is going to date me. I was going to say I'm going to do the Micro Machines version. Nobody gets that reference. I'm going to do the super fast version of this, and then anyone who's interested, or if I can elaborate on anything, we can connect offline. But what I really want to do is make time for everyone to have some discussions and parse some of the things we've heard about today. Some themes certainly came to mind for me, and I've been sitting here taking notes kind of feverishly. So I think I alluded to this a little bit, but Amanda and I were both having a conversation right at the beginning of when we realized that this really was a pandemic, and said that we only knew about 20 or 30 of us that had this background in being designers who had led design programs or teams inside of hospitals or medical centers. I started by saying this is kind of a nascent thing in healthcare, and I can count on maybe 4 hands, if I had 4 hands, the number of people who've led these things or started these things inside of hospitals. Thankfully, that's growing, but it's still a pretty small group of us. And so we got that group together on a Zoom and said, we ought to all at least be in lockstep. We ought to be thinking about the big ecosystem together. If one of us is working on something like creating a guide for testing or a guide for running a hospital unit, we ought to be sharing that stuff openly. This is the time to be collaborative about it. And that really became the catalyst for this whole thing. And what started as 20 people has turned into a collective of 500. And it's a multidisciplinary group that's not just designers, it's doctors, it's med students, it's public health workers, it's product experts. So I'll talk a little bit more about that, but that Genesis story really came out of this idea of deciding that now was the time when we finally all needed to start working together and drop some maybe organizational or ego pretense that had prevented us from doing it before. We've talked about this, that idea that things are too siloed and need to be fixed. This idea that we're doctors and designers working together. I really am going to give the condensed version here. This is one of the things I wanted to make sure I highlighted in our time together. We were kind of brainstorming about, like, how do we describe ourselves? What's the kind of value prop of the EDC here? Bear with me one sec. I've been talking all day. And how do we want to get pithy about describing it? And one of our colleagues said, it's really like, there's that concept of a B Corp, of thinking about not just your profit, but the idea of social benefit in everything you do. It's almost, we decided we need something that's the equivalent of the H Corp, the idea of not just the EDC, but why is every organization not thinking of the health and well-being of its employees, of its customers, in the health and well-being impacts of the products it makes, and in the impact it leaves on the world. How do we start to spread that message? And so that's become kind of our shorthand for thinking about seeing the impact of health in literally everything, and being very intentional about designing for maximizing health and well-being. We're now over 500 members, which blows my mind because we didn't set out to be a membership organization, and those things are hard to create. And yet this one seems to have a very field of dreams quality, where so many people have showed up and just said, I built products for my life, or I've worked in commercial spaces. I really want to be part of something impactful right now. Having folks like Amanda at the front line, so having other doctors, residents, med students, and nurses as part of the EDC and embedded in projects, has made them feel very grounded and frankly much richer. And then having this broad swath of professional backgrounds. I mean, we've got C-suite folks and very senior, seasoned, in the most mature state of their career folks. And we've got a group of students, interestingly, in the Twin Cities right now, doing some EDC-inspired projects as a chance to try to make an impact in their community. Whole roster of organizations that have lent people or lent resources to helping make this work. It's really been this amazing kind of unlikely bedfellows, is the phrase that Amanda uses a lot, but it's a lot of organizations that wouldn't normally work together so easily. And this is not a complete list in the slightest. These were just some of the folks who showed up for some of those first conversations. When we stood this up, we said, like, one of the things that was really important, like the true north, was the idea of working open and sharing everything. That even if it was raw research, that we ought to put it out in the world, because somebody else might pick it up and be inspired, or it might be relevant to work they're doing. But this is not the time to create encumbered intellectual property. It's the time to share everything. We also said we had to be really intentional about, like, acting now, but also looking ahead and saying, what is the new normal we want to come out with? How do we do that in a people-centered way? Kind of how do we show other organizations the value of collaborative design with a healthcare focus? We kind of came about these areas organically, but we realized that like our prime opportunities for impact are in three big areas. One is design for frontline healthcare and healthcare workers. That's everything from PPE, and I'll tell a little quick story about that in a minute, to the mental health impact on frontline workers. And I think you heard that from Amanda and Matt tonight. It is a really hard environment right now, and we don't often think about doctors as having a social aspect of their job, but I think Amanda made that feel very real. The idea that now all of a sudden you're working in isolation and not with your colleagues, and not even with a detailed interaction with your patients. Designing for vulnerable populations. We've got a group looking at social isolation in seniors. They've also learned that elder care workers right now are not being celebrated like heroes. They're being stigmatized because of the heartbreaking number of deaths in the elder care community. We've got groups looking at the unhomed population and how do we care for COVID? How do we help prevent spread in the unhomed population? People with chronic conditions, even looking at things like access to education. When education goes online, if you only have one device in the house and it's your working parent's smartphone, you may not even be able to go to school, and that has an impact on health. So thinking about vulnerable populations pretty broadly, and then thinking about the new normal. And some parts about that are very sobering. There's a project on death and dying and end of life care in the age of the pandemic. How do we help families have those difficult conversations before somebody ever has to go to the hospital, because they may not have a chance to have those conversations in person if they have to go and get admitted or get put on a ventilator. And then some of those things are more optimistic. How do we start to think about a world that we really want to emerge from this? Is this the chance to rethink retail entirely to be safer for people who work in it, and for customers as well, or to think about small businesses as being a safe and healthy place to work, or having a health impact on their communities? So starting to ask those questions about what comes out of this. I'm gonna skip ahead. I don't have to explain design, I don't think, to anyone in this group, and we've even tried intentionally not, even though it's in our name, not to be hung up on talking a lot about the stages and process of design, but we have tried to dig in on the idea of working really quickly in sprints, and kind of evolving the work as we go. So the first step is usually a phase 0 to understand the landscape of a problem, and then that turns into more discrete challenges that teams can take on and kind of focus down on. A real quick case study here, and then I'll maybe turn this over so we can jump into the interactive part of this. One of the first projects, unsurprisingly, because it was such a pressing need, was around PPE. And I think that that's a thing that everybody now is pretty well versed in. We've kind of created a nation of lay experts in PPE, and that it is a wonderful thing. It's raised awareness of something that as a culture and a society, we probably took for granted for too long. We found a couple of things that came out of this. One is that there were two distinct use cases, obviously. One is for medical use, and the other is for the rest of us that are trying to prevent the spread. So for the medical use, we realized that most of us have these networks of people that have fabrication centers. IDEO's Fab Shop, Autodesk has a Fab Shop here in the Bay Area. A lot of us have access to or work in or around those things that have laser cutters and supplies and materials in a way of making things quickly. What they didn't have was vetted designs. So this group worked with frontline doctors, including material scientist experts, and the people who do, there's a type of medicine called occupational medicine that is all about, like, how do you wear this stuff safely? Is it effective? Testing these things. So everything from rapid prototyping here with a blueberry container and a paper towel filter, to then starting to produce real prototypes that we could put in the hands of doctors and nurses and occupational medicine physicians to test, to then being able to ship almost 2,000, it's at over 2,000 here now in the Bay Area, and then using those designs to get things printed in New York as well. So creating that kind of playbook and getting it out into people's hands. There's a critical shortage of blood right now in most major cities, so there's a project on blood supply. We also found, and this has been in the news, thankfully, that people aren't going to the emergency room. This actually dovetails, Natalie and Emily, into your experiences, that hospitals started noticing that emergency room volumes were really low. That should sound like a good thing. It turns out it's not. There were instances of people waiting 10 days before going in with a stroke, which is just awful. I mean, it's heartbreaking. It's life-threatening. And there's this horrible knock-on effect where some hospitals were so overburdened in the ICU and so underutilized in the ER, they started furloughing or laying off ER doctors, which is bananas, right? So thinking about how do we create some guidance on helping tell people that it is safe to go to the emergency room, and then helping ensure that it is safe to go into the emergency room. So those are some of the types of projects. I mentioned the end of life project. This is my selling from the stage, as they say. If this work piques your interest, if you're somebody that wants to work on health and somebody that can embrace ambiguity or building order out of chaos as we build this thing in flight, we'd love to keep the conversation going, but don't let me hijack this with my sales pitch. Natalie, let me turn this over to you so we can talk about how we want to make it interactive from here.
Sure. Yeah. And I definitely encourage you to look at the website, the EDC website. We can share out those links and materials and resources afterward. Nick, if you want to put it in the chat, you can, but please join. I recently joined. I know a couple other people in this group have joined and are looking for some projects I can help on. I'd say for the remainder of the time, I do want to make sure I'm respectful. I'm sure many of you may have a lot of Zoom calls during the day. We're going to still try to end by 8. So we might shorten some of the activities. I think it's good actually that we spent more time hearing the stories. I think I haven't had any exposure to the doctors and the frontline stories. So I think it's good that we spent that time. So what we'll do is and Nick, check me if you want to do it differently, is let's spend in the breakout rooms about 10 minutes, maybe up to 15. We'll kind of do a regroup as an organizing team, but we'll put you into groups of 3 to 4 people, and we want you to really just talk, reflect on what you heard, and think about what areas could you solve for? What are the problems there? What are the breakdowns in the system? Those sort of things. So Nick, I don't know if you wanted to prompt them in any other way, but I think the first part is going to be reflection of this. And so we're going to have you reflect in those groups. We'll bring you back, talk real briefly, and then go back into rooms again for ideas, unless you have any thoughts, Nick, on changing that, but I feel good about that.
I think that's great.
Great. All right. I'm just checking the breakout rooms. It'll take about 15 seconds for you to get in there. You all have 3 people at least in your room. Some of you have 4. So just be aware you might be waiting for a third person. And yep, I'm opening all the rooms now. All right.
And
so
I am going to go grab some water.
Oh, sounds good. Hey, Kathleen.
Hey,
Hey.
sorry, I think I just saw Carol as she's leaving. Hold on, let me just thanks for joining me.
Oh yeah, thank you.
Our anniversary. Okay.
Wow.
Happy anniversary.
I'm gonna drag Emily out of one room and put her in another. She's gonna be scared. I figure she could handle it.
Natalie, we have Abby here.
What?
We have Abby here.
Yeah, I was in a room for a moment and then I just came out, I guess.
Oh, why did you come out?
No, I did not come out.
Oh, okay.
Yeah, it just threw me out in this room.
Oh, that's so weird. Okay. I'm trying to figure out how to move you back in. Let's see. So I'm gonna try to. I don't know actually how to put you back in there. Move into a room. You're welcome to talk to us. I'm just looking at, yeah, I'm trying to think if somebody leaves the room, how do you put them back in there?
Is it not like you don't have
It's
like
not
a
clear.
place where you
Yeah,
the
it just,
practice?
Abby, it shows you as grayed out, like you're not joined. I'm gonna try something. I'm gonna move you to 2, 1. Do you see anything on your side? This is a learning moment for all of us. Anything that shows like join a room or something?
Yeah, it says join breakout room.
Okay, can you click on that?
Oh yeah, I'm able to join a room. Yeah, okay. See you guys.
See ya.
Hello.
Okay, he's back in his room. This is so weird.
Why?
Like in the breakout rooms, like, cause it's like, you're in different rooms, but you're not in the rooms. You're like in a video call.
Yeah. This
It's
this
not
was
very clear. They don't make it very clear. They should do like an interface where
lovely.
basically it's like a folder and then you put yourself in there. You know, it's not that clear as
No,
moving something into something.
it's not. I'm just, and I can't, can I share my, do you guys want to see what it looks like? I could show you. Can you see, now you can see my whole talk. Can you see what I'm looking at here?
Yeah.
Is your talk?
Oh, you don't see the breakout rooms?
No.
No.
Oh, weird. So I can't even show you what I'm looking at. But yeah, it does like, and Sam validated my feelings because she said she gets really sweaty when she's putting everyone in the breakout rooms because it's like you're moving humans around in their little rooms. And
Yeah, it's a bit.
if
Yeah.
you move them wrong, like I know when I moved Emily, she was probably startled. She was like talking like this, and then she was then it was like great. And then she was in a new room with new faces. Like it is very jarring. But yeah.
I agree.
No, we'll just see. So they start at 7:13. So I figure this is where I get really bad at math. This is where Nick and I talked about TikToks, like the very like organized Excel. Without my TikTok, I feel now I have to be creative.
And then I ran everything off the rails.
Oh, it's fine. I think I figured the conversations, I don't think you did that. I think it was like positive that people were engaged and had questions.
Yes.
It made me think about this as, it's hard to do longer workshops. People are tired with their eyes and everything, but like, I feel like this is a really engaging subject matter and it would be interesting to have like a more of a forum, but people get zoomed out. I'm gonna get water too. That was stressful.
Yeah, I agree. Like today I was on the call with client for like 2 hours and then I was just like, oh my God. At the end I was like, man, my eyes are like, ugh.
Yeah, I know. I'm struggling right now, actually. Like I'm not looking at the screen. I'm just like looking at it's. Yeah, I've been struggling today. So,
Welcome
started.
to my world, Antonio.
yeah.
Sorry.
I've been calling it like at the end of the day, I feel like I have Zoom voice. Like I get scratchy, my voice, and then it sounds really odd. My tongue gets really like sore and fatigued. There's something about the way I'm projecting when I'm on these things that's different than if I was just talking.
I know, because you project more. Yeah, I know. You don't talk normally. I mean, I'm talking normally now with you guys just because
Yeah.
it's like a very informal situation, but otherwise you talk like you're in a meeting because you are in a meeting.
Yeah. And the call with client, it's recorded, so then people didn't join can listen later. So then I was like, okay, let me articulate the point really well. So people join later will understand.
Yeah.
Yeah, it's hard.
It's a whole new world. Yeah, it's the workshop part of it. And then like no matter when you start the event, people will always be late then, and then sometimes they do miss something critical and it's hard to help them because then you have to tell everyone instead of like individually being like, oh, that looks confused. So I see I'll help one. Instead you have to be like, if somebody has a question about that, and it's like.
I mean, in theory, you could, someone else, if you're another facilitator, could talk with the person in the like specifically, but it's complicated, right? Because everything is like flowing on your screen and it's not easy.
I don't know if you guys have this problem. Sometimes because we use WebEx, so sometimes I use my WebEx to open different meetings. But let's say if I go overtime, then the next meeting participants already entered this meeting, but my meeting is not over. And I was like, can you just get out, like join later in 5 minutes? I'll ping you guys and stuff.
Those are all things that Zoom actually should fix or could fix,
Yeah.
There's a lot that it could fix. But yeah, I mean, I'm excited about this material. I think, and I've been looking at, we have about 30 people. So Nick, and I don't know if I can't remember what I said in email. I feel like I'm pleased with the turnout, with the feel like things that are happening in the world right now. And I don't mean to dance around racism and the systemic issue we've created over hundreds of years. I'm just like really like struggling with words, but I think that people are overwhelmed. They are zoomed out. They are some of the most engaged people in our core team have apologized. Like Darren, actually, for the two of you guys, Darren and Madison have been like, I'm sorry, I just can't. And then Caroline is like, I just can't. And so I think that I'm just reflecting on the number of people, and I think this is something folks are really engaged with, and most of the ones that joined have stayed on the whole call. I just felt bad, Nick, because I think I said some sweeping statement in the beginning, like, we'll have a minimum of 60, hundreds will join, and like in the beginning, like a lot of people were joining, but now I feel like with everything going on, people are like, whatever you have to say, I'm just like at capacity with what's happening in my life.
Yeah, I have no value around number of participants. So this for me has been great. And when this all started, a colleague of mine said 2020 is the year when none of us get to have ego. And I also feel like it's the year when we just all let each other off, right? If you don't make it to something, you don't make it. And if you do, you do. Like just all the things, those little precious things around schedules and RSVPs we used to treat so delicately. It turns out it just doesn't matter that much.
It's a good
no, that's totally true.
Somebody had said that actually, Saad is in here. He came to one of our Humans Diary sessions. That's a whole other project, Nick, that Antonio and Kathleen and I have been involved in. And he had said that you used to take it personally if someone like didn't come to your birthday or couldn't come to some celebration. And now it's like these two layers. One, well, you might not feel safe to be socially distant from me. So that's your safety, and that's not something I'm going to question. And if it's online, there's other issues, but it's like this, letting people off the hook because everyone is processing this differently. So,
I think someone just came out from the breakout room.
Hello.
Hi, Maria.
Hi, Maria. Did you want to come out to talk to us, or did you do that by accident?
I think she's on mute. Hi, Maria. Are you there?
Yes. Hi, I'm here. Am I supposed to go back to breakout? You guys have a separate conversation. Sorry.
Yeah, no, it's okay.
No, it's fine.
Taking a moment of just quiet chats. But yeah, we're staying in the breakout rooms for a little bit longer. So if you want to go to the lower part of your screen, it should say something like join breakout room. If you just join breakout room, you can go back, I think.
What is there anything planned after breakout room, after the?
Yeah, we're going to come back in a few minutes and share as a bigger group about what you talked about in your small groups.
Okay.
So yeah, you just have a couple more minutes.
Oh, can I just mute myself and turn off the volume and stay?
Sure, yeah.
That's fine. That's fine.
I'll send a reminder to folks that we'll bring them back. I mean, it has been 10 minutes. So I'm going to send them a message and just say we're going to bring them back to the main room.
And I have a question for Nick.
Yes, yeah.
Do you, I mean, I've been volunteering and building something with one very interesting group. And our projects, it's also a healthcare project. We've been thinking to merging with another bigger group because for various reasons, but I don't know if you guys need any more volunteers or even like form team of volunteers or user researchers.
The short answer is almost certainly, yeah, there's a way that we can figure out a way to collaborate. We're still, one of the things I posted in the chat is that we're still growing so quickly. We're trying to learn how to, like if somebody says, I want to help, we're trying to learn how to act on that call to action really quickly. And right now we're a little slow to it. What's the project your group is working on?
We're building this healthcare application that regarding briefing and vital signs and so on, but there are many branches of this project that I feel like could benefit from just more people in, there's just too much work. Yeah.
Yeah, let's, why don't you and I connect by email offline and figure out a way
Sounds
to,
great. Yes, please.
Yeah, help move forward.
Would I, post your email maybe here? Or?
I'll do it, yeah.
Thank you so much. It was really fantastic idea.
Welcome back, everyone, from your breakout rooms. Hopefully you didn't have too many technical issues. I think we're all getting familiar with these spaces. I'd love if folks can share. If you feel comfortable, we'll just do a few minutes of sharing what you talked about in your group so others can hear. And I'll just leave it like popcorn style, like just someone share. And if we pause for too long, then we'll talk about our next steps.
Yeah, we talked about, hi, I'm Saad. We talked about like the different sort of, based on the stories that like you guys were sharing and like, and then kind of from our experiences to kind of like identify like the most important area that we think could really be helpful to focus on. And then I feel like what we identified was like, just like the diagnosis part being a really important area where like the helping the patient sort of determine their understanding what symptoms they have, like how much, if they have it, like the condition or not, and then if they should go in or not. So like kind of like, and then incorporating telemedicine in a way.
If you're not speaking, please go on mute. Thank you.
And then using telemedicine to kind of bridge that gap to somehow help get those questions answered with like a real professional. So that way it can help like the whole system all around. So that's something that we were basically thinking about the team.
Thank you. Who wants to share next?
Yeah, I'll share what we talked about in the group. So, you know, after the brief moment that we had with the surgeon and she was answering my questions, I thought that is really important that, you know, as, you know, designers, we create technologies and systems that can facilitate a really top-notch remote care experience. It seems like that's priority. That's really important. You know, there are existing technologies and emerging technologies that are coming onto the market, you know, that we can leverage that would be able to, you know, make a remote care experience a great one, you know, and just, you know, starting from something, you know, really simple and then being able to scale the experience, you know, into something big. We don't have anything like that right now. People are just using Zoom and stuff, but everybody uses Zoom and Slack, and you know, these are more for technology companies, not they weren't designed specifically for you know, medical teams and hospitals, and you know, that really needs to be taken into consideration, those unique challenges and experiences that they face. So yeah.
Yeah.
And if I can just pick up on both of those, you both have that idea in common of working on like using telemedicine to one, and diagnose, and then two, to kind of think about the user experience of that. And I don't know if anybody, if you've ever experienced telemedicine, if you've ever done it either pre-COVID or post, it's one of those examples in healthcare where by and large, we took the existing behaviors and modalities and just ported it over. And this would be a really good time to stop and think, how do we make that a much more patient-centered or user-centered experience? Right now, it's still very much, you know, that you kind of defer power to the physician. The physician kind of drives the conversation. I mean, it's still kind of clumsy and awkward. And there's just a tremendous opportunity to rethink designing the experience of a telemedicine visit.
Actually, I want to piggy off of that. My name is Linnea. I'm very new to service design, but my parents are frontline workers. Hi, everyone. And something that I'm wondering is, how do you transition from an office communication to virtual communication? And my group and I were talking about like the transition period of like the situation. Like, you know, like we are on Zoom and we say words like, I'll circle back with you like offline. Like you can't exactly say that to a patient. So it's kind of like figuring out how do you standardize that communication and like the language and the word choice that you use. And so I'm very interested to see if Emergency Design Collective is working with something like that right now.
Who else wants to?
The short answers are not. I'm just making a note in real time here. I love the idea of like a script, almost like a new set of vocabulary or a new, or maybe an agenda, like a shared agenda that both parties could have that you kind of work off of or something. There's something really clever there. So yeah, I'll certainly take that one home.
Just a +1 on that. I think we need a new vocabulary to ask one another how we're doing. I saw an article that listed all the different ways that you can ask a person, like, how are you taking care of yourself? That's the only one I can remember from this long list. But yeah, I think that's another, vocabulary is important. Who else wants to share?
I'll share, Natalie.
Sure.
I think in our room we talked about, well, I know this was one of my big concerns was, and it's just screaming, it's the light has been shined on it this week, that access to healthcare and pretty much access to everything, education, and a lot, the range in America is pretty wide. You know, other parts of the world, it's also wide, and you think, oh, well, in America, we're supposed to be doing better. But I think between COVID and everything that's come out with the protesters and things that people have been sharing, you know, we're not doing all that much better. And that maybe just needs to be kind of even acknowledged. Because New York, I did a project with New York Cares, and we were just trying to get these kids iPads so they could continue their remote education. And some of them, you know, were living in transitional housing, and they had been waiting a month, so they lost a month of school. So, I mean, there's a big disparity in access to a lot of social services, right here in the good old USA.
Mm-hmm.
Yeah. So.
I'll highlight just 2 quick facts that this group may well know, but I think is important in this conversation. One is there's the WHO, the formal line WHO puts out a ranking of health systems, national health systems. In other words, how good is the health delivery and clinical care in each country? And then they also put out a correlating data point around that. So over consistently, America has always been in the 30s. We continue to fall. Last I saw, we're 42 out of however many 216 countries in the world. We rank well below most other developed nations, but we're #1 in cost. So we've got that going for us. And in most major cities in urban areas, there's a really clear divide around access to care. If you look at DC, in the 2 neighborhoods that are most densely populated neighborhoods in DC, they're also the 2 of the lowest socioeconomic status and have no full service hospitals and 1 grocery store. So we look at the disparity in resources in this world. And so when we often hear that America has got the best healthcare in the world, that's true for a fraction of our population, but not the majority of our population.
I have a friend who works in international health immunization, and one of the projects that she's worked on recently was in India, and it was just about inoculating babies against measles, I think. But the simplest solution was literally, I mean, this is in the 21st century, was getting people to carry a immunization card. And that's how they did it, was just paper. Going back to a piece of paper, people keep track of their medical records, and it's working. So it's interesting. I think probably a lot of the conversations we're thinking about with telehealth, or if you could have devices at home that could help you diagnose yourself. It's yeah, we need to get back to something more lo-fi that works at a community level.
And I think also something we talked about, bouncing off of what Aurelia was saying, it's the disparity, but also something that resonated a lot with me was health from the holistic perspective, the whole person, not just taking into consideration the in-office medical stuff, but also access to food, access to education, access to shelter, all that stuff together. And there goes our curfew emergency alert. I don't know if y'all are getting that.
30 minutes. Really? So that's, I guess, to tell you to go home. 8 p.m. Anybody else want to share before we go back into the breakout rooms? I did move a couple people just so everyone has 3 to 4. because I know some folks had to drop. Anything else to share before we move to the next activity? I'll tell you what it is.
Yeah, I wanted to share something.
Yeah, sure.
And that's just that, looking into analogous situations in service design is so important. And there was a woman who just mentioned about access, limiting access. And my sister just passed away from cancer, actually. And there was an organization called Lisa's Army, and they devoted themselves to developing getting iPads in the hands of everybody, and it was just so specific, their service, that everybody donates to them. It's just really cyclical and really lovely. So maybe something like that can be done, and just that in the face of this new kind of care, what do we call it again? Remote care. It's probably one of the few situations where you can really look at partnering, the idea of partnering with each other, and then developing a new model around partnering in this transitional space. So where people's voices are really, it's not a top down, it really, the people come together, and and the questions that come up and everything, it really is a very rich service design project. So, yeah.
Yeah. Julie, I'm sorry about your sister.
I'd say it's especially complicated in healthcare, right? Like the idea that disparate services coming together is a challenge, but like hopefully painting that great vision, you get people on board, everyone in the canoe, everyone sees what they're working towards.
Yeah, good point. Yeah. All right, so the next part of this, before we'll do one more share out and close toward the end. We're gonna have you go back into generally the folks that you were speaking with. You might see a new face in some of the groups, but to talk about ways that you might address these things. So kind of getting towards ideation, I think having a lot more time, we might come up with a lot of ideas. Try to think about coming up with 1 to maybe 3 ideas at most. Like I would say, you guys, it sounds like a couple groups had started thinking about an area that they wanted to focus on. So, and it's really loose. I know some of you guys have been a part of design jams, and we're like prototyping and making. This is more of a conversation. And we did say in the invite, I think, if you can bring paper or pen. So if you guys are able to take a quick moment as you go into your breakout rooms to grab paper or pen and just like try to use some time to think about a single idea that you could flesh out a little bit together. Like, what would this solution look like? And if you want to come up with a couple, but I'd say like try to focus on one that then you can share with the group. Does that work for you, Nick? Like, do you feel like that's a good way to have our last breakout session?
Yeah, I think that'd be great. I'm anxious to hear kind of new ideas too.
Excellent. All right, well, if there aren't any questions, and I'm looking at some faces, I know you're not all on video, I'll move you back into the breakout rooms, but speak now if you have a comment or question about anything. Great, all right, so you'll be in your breakout rooms again. I'm gonna say another like 10 or so minutes. I'll send a reminder when I'm gonna start to bring you guys back. So I'll see you in just a bit. I think that worked.
I think we have a person here.
Hello.
Hi, Beth.
I'm going to assign you to a room, Beth, so you don't have to be stuck with us boring people. If you accept I think you just say join room, it'll put you in. There you are. Oh, she went in.
Yeah. Yeah, I just got the curfew.
I know, I see it too.
Yeah.
Nikki, you're
hold on, she's back here again.
Oh, Beth. Hey, Beth. Did you want to be in this room, or did you want to be in your, oh, she's having it. When they get disconnected, they get thrown back in the main room, I'm figuring out.
Oh.
So, and they also get unassigned from their rooms if they leave and come back. Like right now I'm looking at 2 Gregs. Like there's Greg is twice in group 4. They like can create duplications of themselves by accident, and then they can also, if they get disconnected, they go all the way out of their room and then they have to go back into it. It's like a, but yeah. But yeah, sorry, what were you saying? Yeah,
I was just saying 20 minutes to our curfew. Yeah.
I like how it tells us no traffic.
Wait, Nick, where are you located? Are you in New York? Sorry, I didn't catch that earlier.
No, I don't think I said either. I'm sorry. I'm in San Francisco.
Oh, okay. Do you guys have curfew today as well?
We do. Yeah. In fact, that's what when you all looked at your phones. Ours will probably go off around 6:30.
Yeah.
Oh, that's early. So you're
yeah. They've been. I think it starts at 7. Yeah.
Wow.
That's really.
Truth be told, we live. If anyone knows San Francisco, we live in the Mission, which is kind of in the heart of the city. But it's just very. It's a very neighborhoody place, and I mean, even last night during the curfew, when I went out to walk the dog, people are sitting on their front stoops, and it feels fine here. And then like a mile away at City Hall, they're burning dumpsters. So it's such a strange juxtaposition.
Yeah.
Yeah. Yeah. I agree. I think Maria is out here again. Hi, Maria. If you just want to take a break, it's okay. You don't need to unmute yourself. We're just chilling here.
Okay, thank you. Thanks.
Don't worry, we're just chilling. Yeah. Natalie, how are things on your side of the town? Because you're really close to Union Square.
Yeah, I mean, at each night around 8 or 9, but I haven't heard anything yet because I don't know how the curfew will affect this, because last night the curfew was 11 and then before that there wasn't a curfew. So usually around 8 or 9 I start to hear the chanting. So I think they must do some kind of either loop or they like have, because it only lasts for like 20 minutes. So it's at a certain time they start like saying something and it's pretty loud so I can hear, and then it kind of fades away. And I haven't really heard any of the destruction that I saw. Like I saw a lot of the broken windows. I sent you and Antonio a picture. Like I saw a lot of damage, but I couldn't hear it from where I was. I also have a noise machine, so that might be why. But yeah, I mean, I feel safe. I don't think anyone's interested in doing anything to the housing or where people are living. I think it's more, if there are individuals who are interested in violence, it is more directed towards the businesses. Unfortunately, I think that also includes small businesses. But yeah, Fifth Avenue was pretty torn up. So
yeah, just be safe when you take your morning walks and stuff.
I go the other way. I think it is like, to Nick's point, you can walk one direction and you see destruction, and then you walk another direction, it's like nothing happened.
Yeah.
So I walk the other way when I walk in the morning. So
okay, that's good. Yeah, just be safe.
although my UPS store, and I think we talked about, maybe we had this on one of our calls, Kathleen, about the close relationships you have with people, like someone you know at the grocery store, like your UPS, like they're not like your friend, but they're someone you always see. The UPS store, their door was smashed in, the glass door was all completely shattered. And that was upsetting to me because I know, like, again, I know the 2 guys who work in there. I see them often when I need to deliver or send things. So that was a little close to home, but other than that, it's been all Fifth Avenue and Union Square.
Yeah. Oh.
We're from the DC area, and we're in the process of moving back when the lockdowns started. So we just decided to wait here until it was safe to move. But I've been refreshing DC news over the last 72 hours and pretty dismayed about the destruction there too.
So no destruction happening during the day, only in the evening, right? Is that correct? I'm also outside of New York, so unfortunately I cannot verify myself anything. I have left several weeks ago. So
that's
that's mostly in the evenings.
Sorry. Yeah.
Only in the evenings, right?
Yep.
Yeah. And people feel safe, right? No one is like attacking each other. People like walking.
No, I mean, from my understanding, and again, I'm not in the protest, so I can't, I've heard mixed comments, but it's a select amount of people, like very few people are creating disruption, even going against the Black Lives Matter movement. It's like in a lot of cases it's white anarchists, and they're doing destruction, and they're actually other people in the protest saying like, can you not do that because it's hurting what we're trying to do, which is more peaceful. And there's chanting and there's walking and there's, I mean, I've seen some interesting like lying down, like there's a lot of quiet vigils and things. And so my understanding that it's a small population of the larger group that is just looking for violence, and the majority of the group is not. But again, that's my perception from what I've been reading and seeing, and there are like a multitude of truths in the world right now. So
yeah,
I don't know, that's my belief, but I would do your research.
Everybody like curious, like people calling me from all over and like asking why police doesn't stop this kind of disorderly like conduct, like you're paying taxes, police supposed to stop these people and help protesters. So do you see any insights being in New York? Like where is police? Like how do they let this destruction happen?
I actually don't really know that much detail of why the police hasn't been out there. Yeah, but I'm sure there are many levels of reasons that's happening here.
Haven't they been out there? I don't know. I guess it probably depends on where you are, but I get the sense that they have been. I mean, how can you, like thinking about the number of people in the protests, how can you be guarding everything, I guess? I don't know.
No, I mean, but there is there is police everywhere. It's just obviously, I mean, it's a very high tension situation. So,
yeah,
you know, and then protesting. I mean, you know, it's I mean, you can protest peacefully, so that's fine. So I think they're being selective on where to be, and you know, how to intervene, and also they intervene a bunch of times, and I mean that's controversial as well. But they do intervene, and that's also part of. Well, yeah, but then yeah, it's problematic. I mean that's kind of a much longer conversation, because obviously if we intervene in an area where there's peaceful people that are, you know, just expressing their ideas, and then you know everybody's in the same situation, and then people that might be there just for expressing their ideas are also stopped by the police. I mean that's it's very complicated. It's not as easy as like, okay, you know, this is not supposed to happen, so you know, I stop that. But then there is also the people. It's hard to distinguish who does what, and that's where we are at now. But anyway, I mean, I think, yeah, I don't know.
How's Williamsburg?
Yeah, they did. I mean, there was, well, that's what I'm saying. Like, we just moved, for example, these boats, right? Like, I was part, I was at the park this weekend, and there were people, you know, doing like some sort of silent reflection, and you know, just expressing their ideas very peacefully in the park. It was a really beautiful moment, actually. But then yesterday night there was also something going on Bedford, and they broke some shops. Obviously, it's not the same people. I mean, we don't know who did that. So, you know, even in the same area, there are very different ways of you know, reacting to the situation.
How's Terika's business? Is everything okay in the?
Yeah, but they had to close earlier because yeah. So I mean, this is actually also impacting small businesses in the context of you know, everybody's starting, you know, it's restarting after COVID. I mean, it's not, unfortunately, it's not after COVID yet, but you know, they're able to reopen their essential. I mean, at least the essential businesses. But then now this one is also coming into play, and so there are more restrictions, and yeah, it's.
I'm sorry, where are you?
I'm in Williamsburg.
Oh, I'm in Williamsburg.
Okay. And Maria, where are you?
Where I am?
Yeah.
I'm near Nashville.
Oh, okay.
Oh.
Yeah, but I mean, I normally live in New York.
I see. You just went there. Okay.
So I'm in touch with various friends, And it's heartbreaking. Like one friend said that people stopping women on the street and asking them to kneel and like kind of degrade them. I don't know if, I mean, it's just really disturbing to read. I'm sorry.
Yeah, there are many things, both like good things and bad things happening at the same time. I mean, yeah, I think it's an expression of so many, yeah, different realities, and some people, yeah, don't express that properly, of course. But mostly, I mean, I know, I mean, from what I see, from what I read, I mean, mostly there's a big, you know, there's like a big movement of people just, you know, just try to express their ideas. I think mostly it's peaceful. Obviously, the accidents that happen are the ones that, you notice more on the press, and they are reported more. But they're like, I know there are hundreds of people just in the street, just, you know, saying that all the things that are wrong should stop, and yeah.
I hate
Anyway.
to interrupt. I was going to bring the folks back since
Yeah, sure. Sorry.
Natalie, I want to say I'm so glad you are well. Thank you.
I am glad that I am well also. Yes, I'll bring the
We're all
folks.
glad.
Yeah.
We all are.
13 seconds. And I love that it gives me a timer. It's just such a weird human interaction.
I know.
Like even if they were talking, it cuts them off and just brings them back.
That's the only thing that is made easy by Zoom, that you don't have to interrupt people. It's just,
it's easy,
come
but
back.
like very not human. We were just saying for those who are
Yeah.
joining back, remember when we used to try to get people's attention in a big workshop?
Hey, yeah, I know.
Back.
Or the fun activity of getting everyone to move from one room to another room.
I know now it's easy.
You have all the power.
It's not.
Natalie has all the power.
I feel like I'm being pulled through a vortex and just like spat out somewhere else.
I feel bad. I'm sorry. All right, so let's go around. I hope to get, we weren't really doing like group 1, group 2, but try to, if everyone can share one person from your group what you talked about as a concept, that would be great.
Hi, my name is Matt, and our group talk about actually is trying to put maybe create maybe one app or maybe one platform so that people can make an appointment, doing like self-diagnosis, and also do the lab tests, like doing make an appointment to go to the lab to do the lab tests. Because I myself, I do a telehealth like last week, and I'm making an appointment on one platform, and I have to talk to the doctor and on another platform. And I have to, after the appointment, I have to go to the lab testing. I have to make an appointment on the lab's website. So everything is very fragmented. So, and every time I encounter a new platform, I feel like I need to go through, I need to go through another like learning curve for each platform. So yeah, I think what we were talking about is like maybe one platform connecting all the patients, and patients can access all the information just on one platform instead of like going to different places or around and people get lost it.
Thank you.
Yeah.
And I know we are short on time, so I would love to talk more about each one of these ideas. And I'll let Nick, if you have questions about these, but I'd love if people just go through, and then if we have questions, we'll save for the end. Greg, were you?
Can I do can I do 5 quick hits?
Sure. Yeah, I see
Okay.
your paper too. There.
All right, cool. So I did all the drawing for my team. So this idea was a playbook card or knowledge article that you can send to patients to explain a certain procedure, so they have visibility into what's going to happen. Here is an online survey that allows you to understand if you need to actually go in, how severe is your case. Here is one that is around crowdsourcing policies and processes. So maybe somebody has a breakthrough that's an innovative idea and they want to be able to share it with like another hospital. Now you'll like this one. This is remote health, right, coming to you. So like in a box, a doctor sends like a thermometer or anything they need to ingest. And then this one is around a directory of options for testing outside of hospitals. Maybe you don't want to go to a hospital, so maybe you need to find like a drive-in testing place.
Are those dry erase cards?
Yeah, so all you do is laminate index cards, and then you use a dry erase marker on them, and yeah, they're pretty handy. This is another drawing that
Natalie's
we talked about.
drooling.
That's
And so-
amazing.
That's super brilliant, yo. I'm gonna steal your idea.
Same.
Yeah, we talked about this earlier. This is something that's always on my desk, which is like, this is the grief everyone's experiencing now, and I need to remind myself everyone needs to get up here, right? So like, be positive and lift everyone up. So yeah, that's it from our group.
Thank you. Next group.
All right, I guess I'll go. So I'm Barry, guys. Nice to see everyone. The big thing we talked about was building the bridge between someone in the medical profession that has years upon years of training in the medical nomenclature versus a patient that may come in and say, my side hurts. And there's a really big divide in who has the power in that relationship. Bianca had mentioned that she read an article that talked about you really are the master of your body. You know it better than anyone else. So despite what the doctor knows, you are really in control of what you know. So we just postured and talked about how, you know, maybe the intake forms should ask questions that are a little bit outside of the box. Sort of one question we came up with was just, have you told anyone else about the issue you're having? Where maybe it's not, you know, so clinical in that, wait, is this a really personal issue and they're finally sharing it, but they've had it for 6 months? Like that lump should have been checked out, you know, 5 months ago. Like, I think just it improves the communication and levels the playing field if we humanize some of the questions we ask to people when they come in for medical services.
That's great. I hate being like next, but I know we're short on time. Thank you, Barry.
Okay, well, our group also was dealing with remote care, and I think there was a big concern about prepping, and that people aren't prepped for it. They don't even, that idea doesn't come in, so they don't feel that once they're in there necessarily that they're getting the care that they had expected they would get. And so they thought, so our group talked about how we should maybe, like the woman was talking about how she actually did go in, she had a foot problem, and that maybe she could have videotaped her gait, or, you know, or just said, you know, can we do, you know, have a process for what can we do in advance so that the time that we spend face to face is really well used. So that was really an important thing. I think there's this whole idea of pacing, you know, and expectation setting, because it's a new medium and people, you know, don't know. They feel we felt like, oh, we could easily feel really rushed. And since we're talking to a screen, it's not so warm and cozy as it is, that, you know, maybe there needs to be some expectation setting and not to be so influenced by pace, because it really, or you're using your time well or whatever. I mean, those time management issues came up a lot. And let's see, was there anything else? Yeah, just the multiple app thing was really not well received. It was just, you know, it's very stressful to have to do it, and then they have a waiting room, and, you know, it's just maybe the waiting room isn't being used well, and it could be used better. Yeah, and just around norms. I mean, it's just a new world, so that needs to be considered, talked about, you know, just better anticipated. Yeah.
Yeah, 100%.
Yeah.
How many groups do we have left? Who else wants to share?
Our group, I mean, our discussion revolved around the limitations and boundaries of remote care, as Jonathan mentioned, like when should I go and see a doctor, because not every time I can just manage things on my own. And also Kate brought up something that was mentioned during Amanda's and Matt's presentation on the workload and how the workflow for workers in the facilities change, and it's very hard to deal with, as especially when many patients are coming into the facilities. So we were thinking of something, and also the decision of a patient to actually go into the facility, like when is a good time to do so. And also this range between lo-fi and high, like technologically driven interventions. So we sort of tried to connect all of those dots, and we were thinking of something very connected to everything, not everything, but most of the solutions that have been shared so far. So starting from a very lo-fi strategy, which is sort of like a guide that might be developed by conditions or something for patients to be able to make a decision on when to take care of themselves at home or get remote care, or actually having someone coming to your home or going to a facility. So that might be go along with some devices, depending if your condition needs certain procedures to be done. And also that might be connected to what happens in the facilities. So workers can also schedule and manage resources, both human and the resources they have in the practices. We don't know yet how, but the idea is to connect those two ends of the process.
Wonderful. I think, do we have one more group, or was that it? Or do we have two?
I can speak for our group, Natalie.
Oh, great.
Aurelia, hi. I think we did a lot of talking, and I think a lot of these digital solutions or anything that is online, and I think the big lesson from this COVID taught us is we are so interconnected. Whether it's just like the delivery guys, or if you don't realize your mail has kept coming, and the garbage people. So any kind of solution has to touch everybody. Like if you look at what they're doing with contact tracing in the UK, they're admitting that if everybody doesn't sign on, whatever they do is never going to work. So how do we get to the largest number of people? There's a lot of issues with data privacy, language, and then again, maybe undocumented people might not be willing to open up their Bluetooth to say where they've been. But as we've all discovered, if everybody doesn't get tested, we're just going to be back in quarantine again. So is it a level of comfort? Is it analog? Is it going right into communities? Is that safe? And I think that seemed to be a really big challenge. And is it a combination of analog and digital? Because we can't forget marginalized communities at all anymore, because a pandemic doesn't care.
Yeah.
So I think it's a really big discussion. We're learning so much. I mean, in the US, we're learning so much, and we did talk about it. And I've been in a couple of other hackathons that I've been in. Data privacy has been huge.
Yeah.
I mean, even with like senior citizens that don't trust the digital, to younger people that really don't know how to write very well because they never learned cursive. So
yeah,
how can we do this? And we got to find a way.
Yeah.
Yeah, together.
Yeah. I think you may have been the last group, but I'll just pause in case, because I know we're over time. I want to be respectful. I love cats. Emily. Well,
Ray
yeah.
has opinions.
Yeah. I just appreciate you guys taking the time this evening to chat with us, hear some stories, get to hear about the Emergency Design Collective. Nick, are there final thoughts that you have?
Yeah, just a couple quick things. And if folks have to drop, we understand, of course. One is thank you all for inviting us in. Thanks for letting us be part of your network, even for a little bit of time. Thanks for being open to the idea about talking about health and what we design. And I hope if we did anything tonight, it was to continue this conversation that we're all having just about our interconnectedness as humans, and how everything in our lives impacts our health, even when we don't think about it that way. And the things we make, the things we build, the things we experience, all have a health impact. one thought that I had, I wrote down things about every single one of those ideas, and we don't have time for me to celebrate each one of them. But please know that like I've got a copious thoughts here, and would love to dig in on that stuff. But the theme for me that I'm emerging with right now is that idea that we have a new world, whether we wanted it or not. And we have a new opportunity to design what we want. So for years, if you had proposed the one app idea, right, that there would have been 100,000 people in healthcare who would have told you all the reasons it can't happen, and they're all wrong, and they're not around right now. They don't have a leg to stand on right now. We have an opportunity to build the things that we want that will make the world a better place. Right now, there are literally some changes in health policy that were enacted to make telemedicine more accessible. So the government relaxed a lot of the things that made people really afraid to be innovative in health. I wouldn't want to use the word exploit, but I might use the word hack. This is a really good time to be thinking about hacking around the system and building the one app, building even just rethinking the power dynamics. Barry, I think you did an amazing job of like, that is the root of the issue, right? Who has the power and who doesn't in the relationship? Well, in a Zoom visit, it doesn't have to be that way. So what's an agenda we could design, or a script we could design that gives the patient the power in the relationship in that moment in time? I won't keep speaking extemporaneously. I'm loving all of this so much. I'm just really loving the energy and the openness you all brought to this. Thanks for inviting the EDC in.
Yeah, thank you again. Thank you, everyone. Happy Service Design Day. I know it's a day post, but yay, service design. And I hope that you guys can find some way to take care of yourself and take care of those around you during this time. So just make sure to check in on yourself and check in on those around you, and just really appreciate you all. Thank you for coming. Bye.
Thank you so much.
Thank you so much, everyone.
Thank you.
Take care.
Bye-bye.
Bye.
Everyone.